Oh, thank you so much. Good morning, everybody. My name is Kat Chung. I'm a geriatric and palliative nephrologist at the University of Vermont and the interim director for the Center on Aging here at UVM. Very happy to welcome all of you to Grand Rounds today and to introduce you to Jason Garbarino. The topic today, as you all know, is nurse-led Medicare annual wellness visits. Um, Annual wellness visits, as you may know, provide an opportunity for patients to discuss a wide range of issues and concerns that might have been overlooked in a typical visit. And this includes screening for cognition, mental health, home safety, food insecurity, and other social determinants of health that are really key for our whole population, but especially for older Vermonters. And it allows healthcare practitioners to then build a proactive care plan and address emerging healthcare issues and really better understand and appreciate the context in which the patient is living. Annual wellness visits also generated additional revenue, but primary care providers generally feel like there's competing demands to prevent that really prevent them from having these annual wellness visits and conducting them. Hence the utility of having and promoting nurse-led annual wellness visits. So I'm pleased to introduce Dr. Jason Garbarino, previously a faculty advisory board member at the Center on Aging, which is how we met, and is now faculty liaison for the Dartmouth Center for Health and Aging. And he assumed the role of talent director for healthcare at InSpring in 2023, where his primary objective is to contribute to global growth, diversification, and advancement of professional nursing practice. So without further delay, please welcome Jason Garbarino and nurse-led Medicare annual wellness visits, and stay tuned for question and answer at the end of the presentation.
Terrific. Thank you, Kat, for that warm introduction. And I think you pretty much went over all the main objectives, so we can jump right to the Q&A today. I'm just kidding. So as Kat mentioned, I have been a registered nurse for 16 years. I live in Jericho, Vermont. And I'm really grateful, in addition to my new role, that I've been able to continue my role at the Dartmouth Center for Health, which I've been doing for the last 4 years, and maintaining my clinical practice in primary care. So let's kind of jump in to what we're going to really focus on today. I'm going to start by talking a little bit about the Age-Friendly Health System Initiative, which has served as a framework for this work. And then we'll explore and describe the nurse-led annual wellness visits. As Kat had mentioned, some of the things we go into, we'll go a little bit more in depth in terms of everything that we cover in that 60-minute visit that we have with patients. Hopefully we'll have some, interaction during the presentation today. I'm going to be asking for your thoughts and perspectives on things, including your thoughts on having providers lead these visits versus having your nurses in primary care conduct these visits. And whenever we're working on projects, I'm always thinking in the back of my mind about continuous quality improvement. What are we doing? What are we doing well? And what are things that we can continue to do to improve upon what we're offering to our patients and to our practice? In 2017, the John A. Hartford Foundation, in collaboration with the Institute of Health Improvement, started this initiative called the Age-Friendly Healthcare System Initiative. And it was really to build a coalition around ensuring that we're providing a holistic approach in the care that we provide to older adults. So it's following a set of evidence-based practices. We're ensuring we're not doing any harm to patients, and it aligns with this 4Ms model of care. Some of you may have seen this framework. This is the 4Ms framework, and really the emphasis is to ensure that we're addressing all 4 of these issues when we're assessing and working with older adults. We're looking at their medications. We're looking at their medication status. We're looking at the medications they're taking. Are they appropriate for the older adult patient? We're assessing their medication status. We're looking at their mobilization. And last, but as they say is the most important, is we're ensuring we're looking at what matters most. So the real goal here is in terms of how this plays into the annual wellness visits, we're making sure that we're assessing these, but we're also acting upon them. If we're seeing issues with these, if we're seeing areas in which we can improve our care and the lives of our older people, we're acting on them. So this work has been funded over the last 4 years by the Geriatric Interprofessional Team Transformation Grant in Primary Care. And this is umbrellaed under the Geriatric Workforce Enhancement Program grants, or the GWEP grants that are offered by HRSA every 5 years or so. The goal of the GET PC grant is to increase student interest in primary care and increase utilization and value of nurses in primary care. So when I was approached by Dartmouth, this is really where my interest peaked. Without digressing too much, in my role at UVM, where I taught for 11 years and I served as the director of their undergraduate nursing program for a couple of years, I saw that there was this ongoing need to ensure that we're providing opportunities for undergraduate nursing students to get to experience primary care. There's a longstanding emphasis on the acute inpatient setting in nursing education and clinical settings. But if we really want to try to meet the need for additional nurses in primary care in the community, students need to be exposed to it. They need to see it firsthand. So really getting the opportunity to get to grow that and host students in primary care has been really exciting. So this is where the grant has been taking place at Apple Tree Bay Primary Care in the north end of Burlington. It's been a long established practice in the north end of Burlington for several decades. And about 8 or 9 years ago now, the University of Vermont Department of Nursing took over Apple Tree Bay and is now run primarily by nurse practitioners. It's a really great model. It's one of the only few in the country where nurse practitioners are the primary drivers of care, and all of the providers there are also faculty within the Department of Nursing. So many, faculty who want to enter nursing education want to maintain their clinical practice. So it's a great model from that perspective, but it also is probably the primary hub for nursing education for our nurse practitioner students. So every day when you go, there's nurse practitioner students there, and I've had the opportunity to get to bridge more and more undergraduate students into the practice as well. Many of you are probably aware in 2011, Medicare switched from the covering the traditional physical exam for older people to the Medicare annual wellness visit. And as Kat said, really the focus is to ensure that we are developing personal plans of care and looking for areas in which we can help to improve their health and well-being. So it's a big shift for patients who are, used to coming into the provider's office and getting into a Johnny right away and having this full head-to-toe physical exam, to where this is predominantly a hands-off visit. We're not also dealing with acute issues when patients come in as well. Don't want to get too far into the intricacies of billing, but a couple of things to be aware of if you're thinking of bringing nurses into this model. These visits can be billed under Incident to billing. And the requirements there is that there is a provider available in the practice in the event that the nurse needs them to come and see the patient. And I'll talk a little bit about the times that I've had to have a provider and come in to see the patient. If you're in an FQHC setting, there is another nuance where the provider actually does need to have a brief face-to-face interaction with the patient. I forgot to mention that the Dartmouth Center has worked with numerous practices on implementing these pieces, including FQHCs. And that really shouldn't serve as a barrier. Rather, it just requires a little bit more scheduling on behalf of the practice to ensure that the provider schedule lines up with the nurse who's doing these annual wellness visits. Providers can do these visits via telehealth, and I hear a lot of rules changing about telehealth in the near future, but nurses are not able to do these visits via telehealth, so that's something also to plan for. What we've established as a good rule of thumb for the practice is to provide the nurses who are doing these, i.e. me, 60 minutes to complete this visit. And that's really because we're doing a really thorough, in-depth review of all of these areas, which takes some, time, especially if they haven't had an annual wellness visit in the past, and there's lots to update and to review on that patient. The providers in the practice get about 40 to 45 minutes, and that's commonly because of just their schedules. It's really hard to give them 60 minutes for an annual wellness visit. So because of all of these changes in practice for the patients, I really preface each and every visit with the same sort of preface that I share with patients, whether or not I've seen them before. So I'll say, Kat, are you familiar or you're aware that this is a Medicare annual wellness visit? Well, just to reiterate, the purpose of today's visit is to go through, let me back up. So this is a Medicare annual wellness visit. This visit is covered by Medicare to you free of charge. And the purpose of this is to go through your records and make sure everything is up to date and accurate. And we're also going to be doing a lot of health promotion and screening. So it's me asking you a lot of questions, but if you have any along the way, let me know. Also, sometimes as we have our conversation today, there might be an indication for you to come back and see a provider, and we can schedule that at the end of your visit today. In terms of Medicare requirements, this is built for patients who are over the age of 65. Also, there are individuals who are on Medicaid who are younger that are also eligible for these, but I would say 99% of the focus at Appletree Bay has been our Medicare population. Medicare requires that they haven't had one of these visits within a year. So when you're looking at implementing these into your practice, you want to make sure that the person who's scheduling these visits is making sure that in their records they haven't had one of these within the last year. Otherwise, Medicare won't cover it. And there's two really types of annual wellness visits. There's the initial annual wellness visit, and this really requires your practice to be savvy and to be tracking when your patients are transitioning from the age of 64 to 65. Because if you catch them within the 65 to 66 window, Medicare will cover some additional services that aren't covered after the age of 65, after the age of 66, including a once in a lifetime screening EKG. Nurses are not able to do that initial annual wellness visit, but any annual wellness visit after the age of 66, the nurse is eligible to do. And I know the word initial can be confusing at times. Perhaps they haven't had an annual wellness visit until they're 77 years old. Well, if they're after the age of 66, it's a subsequent annual wellness visit. Some of the things that Medicare requires as well is that there's a health risk assessment completed. There are some questions that Medicare requires are asked of all patients for these visits to be billable, and practices need to ensure that they're covering those questions. And then it's really up to the practice how they structure the rest of the questions they want to ask. A lot of this is electronically done now, so you can include much of this information in advance of the visit for the patient to complete if they're able. If they're not, it's something, given that we have 60 minutes, we can make sure that we address all of those things. Medicare also requires that at the end of the visit, the patient receives a list of individualized written instructions, which really is a summary of everything that we went over, the key points that they should really work to address based on our conversation to improve their health and well-being. So diving a little bit into what we do with each one of these, we're assessing their height and weight, we're checking their vital signs, we're looking at their smoking, their alcohol history, their drug history, asking about and assessing their sexual activity, checking if there's been any changes over the last year in their medical and surgical history, their family history. These are aspects that, I sort of have set my own bar, my own standard. And, if I'm doing this for the first time with patients, I will, really ensure that I'm going through these one by one. But if I'm seeing them a year later, I know that I can kind of just look for updates. And, if you're doing this for the first time, it takes a lot of time. We're assessing their allergies. We're looking at their fall risk. One of the things that I decided early on in doing these visits is that I would be rooming my own patients for these visits. And the reason I made that decision is, I want to see how they get out of the chair in the waiting room. There's a lot of twists and turns. Appletree is an older building, and there's lots of turns that they have to navigate. along the way to where we get to our room that we do these visits. So it's a great way for me to assess their mobility status and to learn about their fall risk. We're looking at their provider list. Do we have an accurate list of provider that they're seeing in the practice, but also all the specialists that they see outside of our practice? We're doing a medication review. So one of the things that we ask of patients when we call to schedule these visits is to either bring all of their physical medications to the visit, or at least a list of all of their medications that they see as their current list of medications. I'd say about 80% of the patients are really good about bringing a list. And this is really integral where I think a lot of older adults have gotten more and more used to using MyChart, the electronic health record, and seeing that as an up-to-date and accurate thing. But, time and time again, they had a list. They went into, the hospital for an acute event. They had medication changes, and then they're working off an inaccurate list. For example, I had a patient who, went into the hospital for an acute coronary event, had some medication changes, came in and had some adjustments to their blood pressure medications on the acute side, but they continued taking their ones that they were taking before the hospitalization, and no wonder their blood pressure was in the 70s when they came to see me, right? Immunization wise, we want to be assessing their immunization status. I've been talking for a little while now, so I'm going to open it up to have people throw out what immunizations you think that we should be assessing for in older people.
Hopefully pneumococcal, yeah, and flu.
Good. I can't see the chat, so if people are putting them there, that's great. So pneumococcal, annual flu shot, what else?
Shingrix.
Yes, good. The shingles vaccine.
Pneumovax.
Yep.
RSV.
RSV is a new one. Yep. Talk about, continuously improving our practice, being aware of changes. That's a new one. Two more.
COVID.
Yep. Good. And the last one is the Tdap, the tetanus, diphtheria, and pertussis vaccine. That's every 10 years. Great. Thank you. We're assessing their living situation. Who are they living with? What types of supports do they have? This is something that over the last 5 years or so has become more and more prevalent with something, but I like to kind of keep this data because it's pre-COVID, just to show pre-COVID how big of an impact loneliness and social isolation has on older people. There was some data that came out prior to the pandemic that showed that loneliness is more dangerous than obesity and as damaging to health as smoking. Anyone want to throw out a number? How many cigarettes per day?
15.
There you go. I don't know who that was. I can't see the screen, but you won the prize. Thank you. Good job. So, tremendous impact on older people. I think a lot of people, enjoy coming into the practice to, have this hour-long visit with me, simply for that reason. So we really want to look at ways to build community and provide services to older people to address this growing pandemic. What is review? Additional things that we talk about, social determinants of health have gained more traction in terms of the attention that they deserve and need in healthcare. All of these things, many of which they can complete in their home prior to coming via the health risk assessment tool in Epic. Their food insecurity levels, this has been a growing concern, I would say, especially over the last I would say post-pandemic, I think we all feel the crunch of when you go to the grocery store now, a bag of groceries, if you're trying to eat healthy, is, $40, $50 easily. So a lot of older people are feeling that crunch of trying to eat healthy. Many of them come from a generation of really wanting to be stoic and not wanting to talk about it. So really, emphasizing that this is something that a lot of people are struggling with. and trying to find, resources that they're amenable to use within the community. I'll give you an example. There was an older person who shared that she was really struggling with food, but she shared that when she went to the food bank, they gave her this huge box of food. And she's like, I just couldn't eat it all. I felt bad about, wasting all this food that they gave me. And it was just a simple call to the food bank to say, is there a way that you can, sort of modify your standard allotment that you give to people, and here's the issue that was coming up. Or I've shared with patients, well, you could drop it off, the church down the road has a food pantry, so some of the non-perishables, you could drop it off there. So, using a little bit of creative support for patients goes a long way. Assessing whether they have adequate financial to support their housing and their utilities. This is during the visit. We're looking at the United States Preventative Task Force recommendations for screening for older people. We're talking about colonoscopies and mammograms, any ultrasound screening for patients as well, bone density scanning we're looking at as well. We're assessing their diet. What types of foods are they eating? What do they have access to? How do they continue to maintain healthy diets? And what are some strategies, some nutritional resources we can give to them? Exercise, what is their exercise routine? How often are they exercising? When they do exercise, how long are they exercising for, and what type of activity? We're assessing whether they have any hearing deficits and vision needs. There's been some great changes to what Medicare covers over the last year, so hearing aids have become much more financially accessible to older people. And as Kat mentioned at the beginning of the talk today, what is their home safety like? Do they have smoke detectors and carbon monoxide detectors? Do they have hand railings? Are they aware of tripping hazards and loose rugs, things that can impact their safety? Advanced directives, many older people don't have these advanced directives completed. These are something that we have readily available. I'd say I give these out probably 50% of visits to patients. And talking about adjustments again to what we do, year after year, what I've become accustomed to doing is if I'm seeing a patient again, let's say a year later, I usually start by looking at what my recommendations were a year ago. And, if I see that I recommended last year that they should complete their advanced directive and they're coming back saying they haven't, something that I've really started to do is spend a little bit more time going over, what the purpose of these is. And I also mentioned that if they're having trouble completing them completely, in their next visit, bring it back. And that's something that we can help them support them in completing. Kind of tying in the 4 M's, when we look of ways to make sure that we're hitting all of these in our visits. For the mentation, we're doing a mini cog screening. Remember, this is not a diagnostic tool by any means, but wow, what a way to assess whether there is some potential cognitive decline or changes in older people. I taught gerontology at UVM for a decade, and I always taught about the clock draw test, but until I saw it in practice, like, holy cow, it's amazing how you could spend, at this point in the visit, I've probably been with them over a half hour and they've done really well. And sometimes I haven't seen really clear cognitive concerns, but, then you have someone who draws a clock, similar, somewhere between score 4 and score 5 here. What we're having them do is, draw a clock on a piece of paper, analog, not digital, and they have to put all the numbers on the clock, and then you ask them to put the hands at 10 past 11. So a really great way to really quickly see if there's some potential cognitive change. The first thing that we do as part of the mini cog, though, is a 3-word recall. So I share with the patients that I'm going to share 3 words with them. I'm going to have them repeat them back to me and then try to remember them. It's not required that they do it at the beginning of the visit, but I learned during COVID, when you have masks on and you can't hear people clearly, you want to make sure that they actually heard the words that you said at the beginning, because you don't want to hold them accountable for not knowing them if they couldn't hear them when you had a mask on. Then we have them name as many animals as they can within 1 minute. We're trying to get them to name at least 15 or more animals. And talk about a way to have people feel really flustered. They start dog, cat, lion, and then I'm looking at them, they're looking at me, and you can tell they're getting nervous. So just reassuring them. You can't tell them how many animals you're looking for, but just reassuring them they're doing a great job, and the majority of them can get there. Then we do the clock draw test, and then go back to that third word recall. We do the medication review, as I mentioned, going through all their medications, ensuring that the doses that we have prescribed are correct with what they have on their records. I think, big picture, many of the insurance companies in particular have really gone towards doing a lot of these annual wellness visits in the home. One of the things that I would love to continually advocate for is to allow for nurses to be able to do these, because again, the Medicare requirements, they can't do them in the home, but I think it's a really great way to do that full assessment of their medication status. What are those prescription drugs they have at home that they haven't thrown away, or what supplements are they taking that are in the home setting that they aren't reporting, even though we're asking them about. I talked about the mobility assessment. I'm seeing how they move. We do a brief get up and go test. And then the last piece we do is that what matters component. So this is something, and I'm happy to share with Ed, and he can distribute to the group after. We actually had a paper published in AGS probably 2 months ago, really focused specifically on this research that we did. So really intentionally try to ask the same way every time with patients. Currently in your life, in 1 or 2 sentences, what matters most to you? And I'm curious what you think might be the top 3 responses here. When we think about developing and trying to identify themes, what do you think are the top 3 responses we receive?
Family, faith, pets.
Family, yep. Faith, pets, there's another big one.
Independence.
Yeah, good. Independence and health. So the first one by far is relationships. My spouse, my children, my grandchildren, right? My friends, my loved ones. The second is around health, and that really ties in with independence as well, being able to stay healthy, avoiding illness as much as possible, well-being of family and loved ones. A lot of this research was done, I would say, intra-pandemic. So obviously there was a big focus on family, being able to maintain the things that I enjoyed doing in life. And then the third one was hobbies and interests. But also, this is something that, again, intentionally I do towards the end of the visit, because I think that this is a question that is helpful to have an answer to once you've built a little bit of rapport. And I think people are a little bit more honest, possibly with their responses. A lot, many are well aware of global affairs. This is another big theme. Yesterday I was doing these, and a lot of, I had 4 patients yesterday, and 2 of them, said family and also what's going on in the world right now. The geopolitical scene is really frightening to me. I'm worried about my grandchildren's future. That's, I would say, a growing theme. There's also, I've had examples of things like fixing the leaky hole in my trailer. So I had completed that social determinant screening around, do they have adequate finances? And there was really a negative screen there. But that type of response, yields opportunity for a little bit of an additional investigation on my part. So tell me a little bit more about that. And, the patient went on to share that in her trailer, she had been having a leak in her roof for the last few months, and it was growing mold into her trailer, and it was causing her husband to have a lot of respiratory issues, and they couldn't find someone to fix it, right? So this was, an opportunity for me to get to reach out and try to identify some community agencies that could help support the individual in having this issue addressed. So seems like a really simple question, but it can really give us a lot of insight into what people are thinking. I'm all about the low and slow approach. I've learned that, if there's a patient who says they're eating like crap and I say, well, stop eating like crap, or, I'm not doing any exercise and I say, I hope to see you at the marathon in May, it's not, a good approach to trying to make lifestyle changes. So there's a lot of, great applications out there in tech that help support people in their journeys. Some of you might have seen commercials for things like Noom. The research shows us that if we're tracking, the things that we're trying to do, the higher success rate people have. So, can people start to track their weight on a daily basis? Can they start to, check their blood pressure more regularly? We don't have a lot of time, but I think alcohol use disorder is grossly underreported in older people. I have many older people who, disclose the amount of alcohol they're drinking, and have shared that their drinking has increased as they've aged. What do you think are some reasons why some older people might start to misuse alcohol?
Grief.
Absolutely. Yeah, good. Grief and loss. Mhm.
Loneliness.
Loneliness. Absolutely. Right. Lack of routine. They don't have to get up, at 5 o'clock in the morning and get ready to go to work anymore. There's not people checking in on them. So it was actually a patient who introduced me to this app called Reframe, that again, provides these little daily lessons, provides opportunity for people to track their alcohol use, and is a great way that has helped them to cut back. And so these are the things that I try to share with patients as tools for them to improve their health and well-being. So want to take a little bit of time now that I've kind of gone over what I do to talk, about what you think might be some of the advantages of nurses having these visits in your office and setting versus having providers do them. What do you think might be some of the advantages of a nurse doing them or some disadvantages and vice versa?
I think one of the advantages for nursing is, these visits are intended to be a wellness visit. And when you're with a provider, they say, "Oh, my knee hurts," and "Oh, I need an injection in my shoulder." And then you end up, what we find is that we're billing, right? We're billing a modifier. And so they're getting a charge for a visit that they think is free. So I think having that line of being like, well, I'm not able to do that, but I'll refer you to your primary care.
Spot on, Courtney. Absolutely. I'll jump ahead to a slide here to show a picture of my buddy Mater here. So I don't know if anyone's seen the movie Cars, but when I think of what patients try to do, and I think it's very similar to when you have a car that's at the end of life and you're going into the mechanic and you're there for an oil change, but you try to be slick with them and say, "Oh yeah, by the way, can you check that clinking noise and the smoke coming out?" Right? It's very easy for these visits to become that, where the patients say, "Oh, I started coughing up blood yesterday," or "I've been having a lot of shortness of breath. Look at this pitting edema in my legs." These are things that need to be addressed, and in some cases acutely. But that's why so many of these boxes that we want to check, we want to, ensure that we're addressing with people, end up not being able to get addressed. And then also, to Courtney's point, the billing component, we really want to ensure that when we say this visit is free of charge, that it remains that way. And if patients do have other issues, to come back and see there's a clear line in between what I can do as the nurse and what a provider would many cases end up going over during these visits.
A lot of times what we find as well is that their acute issue becomes the need and the desire and the want. So then they push off the wellness visit and it just doesn't get done.
Absolutely. Yep. Thank you, Courtney. Anyone else want to share? All right, so a little bit of summary. I think Courtney hit a lot of these. The health promotion piece of checking all the boxes, the time, it's very easy if patients have issues that we need to deviate our attention to, understandably. We don't have time then to circle back to completing those. I think over the last 4 years, I've developed a pretty good personal toolkit of the community resources that are available to the older person who's experiencing various issues. It also builds a nice relationship, I think, between the practice nurse and is a great way to fuel RN retention. I've, consulted to many primary care practices, and I had a physician come up at the end of one of my talks on this, and they said, more than anything, I think our practice really needs to develop this simply as a strong way to encourage our retention. I think our nurses are sick of spending 99% of their day on the phone. I think if practices look at ways to maybe fill that person who can answer calls for, let's say, one or two of these visits a week, I think that the nurses like the opportunity to get to see patients face to face. And then when that patient's calling back with questions or concerns, that nurse has a bit of a connection with that patient. So there's a lot of opportunities to utilize your nurses in ways that I think will ultimately fuel your nurse retention. There's also a lot of system value to it. So this is my big doom and gloom slide of the presentation, and this is data pre-pandemic that I like to show, just because prior to the pandemic we were in a bad financial crunch here in Vermont. I've served on the Green Mountain Care Advisory Board for the last 5 years or so now, and this is data that showed prior to the pandemic 7 of our 14 hospitals in the state were in negative operating margins, and we know now that that really all of them are in big financial struggles. And this is the information in terms of how much Medicare reimburses for these to be performed by the nurse. So, when we think about provider time and the other things that they could be doing, a lot of practices now are turning away patients because they don't have enough provider time or providers. This is a really great way to open up their bandwidth. So you're getting the win of still having this revenue come in for a nurse who's not making $130 an hour. So it's a money increase for the practice in addition to those additional patients that now your provider can see. So really utilizing nurses to their the higher scope of their practice. I mentioned earlier that the providers need to be available in the event that the nurse needs them to consult. And I've done probably 400 of these visits now, and this is the entire list of times that I needed a provider to come in and see the patient. Someone had a recent tick bite, they had a bullseye mark. I wasn't going to send them out of there without some assessment and antibiotics. I had a patient whose blood pressure was in the 220s. I also had another patient whose heart rate was in the 170s, 180s, and another patient who was in SVT. Never fun when an annual wellness visit turns into a trip to the ER, but it does happen. And then I had a patient who had to get up twice during the visit to go to the bathroom. She had multiple UTIs in the past, knew she had a UTI. Again, I wasn't going to send her out of there without having a provider come in. So in terms of what we've done since we started these in terms of process improvement, one of the big things is that patients were coming in, they're seeing me, and when we started these, we weren't doing routine lab work. Some of these patients were, not coming in. They hadn't been in the office for 4 or 5 years. And what's the likelihood of them coming back again, after this visit? It's potentially low. So we started a screening protocol where if patients haven't had their basic metabolic panel or their lipids checked in the last year, that's something that I can order as part of the visit. So we have that data available, which is helpful. The calls to recruit for these, it's really important that you develop a script, because if you're really setting up your nurse and your patients for success, it's important they have an understanding of what this visit is. I've only had 2, maybe 3 patients storm out, not happy with what they were there for. They thought they were seeing their provider. This was a waste of time type of thing. But, you know, you want to have a script where they're aware that they're going to be seeing the nurse, not their provider, to get them to bring in their list of medications, etc. Really sets up the visit for success. And it's, you know, a great, you know, one of the things that we found is it's important that I'm sharing information with the providers about what I'm having the patient come back for. So, for example, I noticed that their blood pressure has remained high and their blood pressure is in the 140s. So, you know, I'll message the provider to say, I sent that patient home with a blood pressure log. They're going to log their blood pressure once a day over the next 2 weeks, ask them to put the time in which they check their blood pressure. Go over with them how to appropriately check their blood pressure, because many of them are not doing it correctly at home, and telling them that they're going to come back and see them in a couple of weeks. So I want to make sure we have time for questions, but this is a really brief survey. We started towards the beginning of these. I wanted it to be short and sweet. It was just a 1-page 4-question survey that I had patients complete in the waiting room after the visit, just to make sure that we were, you know, doing a good job from their perspective. And the data overwhelmingly showed that they were satisfied with the visit. They found it to be helpful, that they'd recommend it to a friend. And the last question here about it being conducted by a nurse, would you prefer to have it done by a nurse, a provider, or no preference? A third of the patients, about a third, said they'd prefer a nurse. 2/3 said they would not, they don't have a preference. But, you know, this really, the big takeaway for me in this was, well, I want to know more. So, you know, we don't want to belabor a patient with a longer survey after the visit, but it's reassuring to see that those that we did survey really found the visit worthwhile. Talked about this earlier. The age-friendly health systems I talked about at the beginning has 2 real levels, and this is a designation that I encourage really all of the practices, all of the healthcare systems in Vermont to really undertake if they haven't already. It's a great way to educate your staff and to really think about the focus of the care that you're providing to your patients. And there's 2 levels. The first is really just saying that you're going to dedicate time within your practice to implement these 4 M's. And then at about the 6-month mark, they ask for some data to demonstrate that you have implemented this into your settings. And really pleased to share that Appletree Bay was the first level 2 age-friendly health system in the state of Vermont. So just a little plug for this, and to encourage all of the practices to look at this. There's a tremendous amount of resources available, toolkits, to make this an easy process. But I think it's a real great way to frame the care that you're providing. So in summary, I'll just say, due to time, I think that I found this to be a call for practice change and system change. We all have in our minds what's most important. And we all are familiar with electronic health records. Many of them have these banners towards the top of critical information. I would love to see patients' responses to the what matters most question to them towards the top of that. So, you know, whether the patient is in the ICU and, you know, you have that data available, I think it's helpful. If you have a patient with dementia who's in the emergency room that's confused, and, you know, the response to their question was my husband or my cat, you know, that helps to really break the ice and develop a rapport with those patients. So I think, you know, regardless of the setting, there's great opportunity to ensure that we're looking at addressing those 4 M's. As I open it up for questions, I'll put it in the chat as well, because I want to get rid of the slideshow so I can see people's faces. But my email is here, my phone number is here. I am, you know, really dedicated and passionate about helping practices to implement this. Dartmouth has a lot of resources available to train staff and to build these changes. So if this is something that I can help in your settings to implement, I'm more than happy to do so. So I'm going to stop sharing and open up our last 15 minutes or so to questions.
Shirley, would you like to ask your question that's in the chat?
Oh, sure. Yeah.
All right, so I have a
Thanks,
couple
Shirley.
of questions for you.
Yeah.
So one of them is we also do the lab work, like if someone's due for it, but what we're finding is if someone's coming in and they don't have a specific diagnosis, then they can end up getting billed for the
Sure.
lab work. So just that was one of my questions. And then another question is I looked up on the like the Medicare, the website, as far as who can do the wellness visits, and it says like a the way it's worded, it's like like as a healthcare team.
Mhm.
So I wondered thoughts on that.
Thank you. Great question, Shirley. So number one, for time, if you email me, and I threw my email in the chat, I wasn't clear. I'll share with you the screening protocol that we made, and that diagnosis has to be there for me to order it. Okay. Yeah. Thank you for that. Number two, there is a broad sort of definition of who can complete these. I haven't heard of practices using medical assistants. Frankly, I haven't heard of LPNs either. It doesn't mean that they couldn't. I have heard of pharmacists completing these in addition to nurses. I would say that, I've been a nurse for 16 years. I think it does require a bit of knowledge, and you need to have comfort. And I think one of the things that is, I feel very grateful to have implemented that I'm at Appletree, where I've had relationships with the providers there for many, many years. There has to be a strong level of trust in the person who's doing these that's not a provider, to ensure that they're staying and maintaining their scope of practice. It's very easy for someone to say, I have allergies, and, for someone to start, recommending medications. That's a big no-no, right? You want to make sure that people are aware of their boundaries when questions are asked, that they're answering them appropriately. I think having a nurse with some foundational knowledge of being able to answer some questions within their scope of practice is of value. So I would say, regardless of title, it's making sure that they're aware of their role and their responsibilities and what they can address and recommend to patients.
Okay, thank you.
Does that answer your question?
Yeah.
Yeah.
Jason, can you see the chat? We have a question from Jennifer. If not, I'm happy to repeat that, or we could have Jennifer unmute.
Jennifer, are you in an FQHC by any chance? Are you not part of an FQHC? Okay. So I mentioned briefly at the beginning, but this is a really good point to reiterate. If you're in an FQHC setting, Medicare does require that the provider does complete a face-to-face at the end of the visit. So Dartmouth has worked with many FQHCs on this. It shouldn't serve as a barrier, but I think it is, important to make sure that you have a scheduler who's able to really make sure that the nurse's schedule of completing these AWVs lines up with the with the provider's schedule. But, I think it, in some cases, that's a really great advantage where, the patient who's had some sudden shortness of breath or, progressive shortness of breath, or has a question about something that isn't in my scope of practice, they're going to see that provider immediately thereafter. I think you do need to make sure that the billing component that the patients are aware of.
So what does that look like as far as documentation, or is there, if a provider comes in at the end, is it, how do you document that to make sure or do you not?
Yeah, I don't want to give you the wrong answer because I'm not in an FQHC. So email me and I'll connect you with Dartmouth to get a clear answer on that.
Great, thank you.
Okay, yeah, sure.
Jason,
RHCs, not sure about RHCs. I don't know the acronym. Regional health centers, is that right?
I would think so, but
rural health
rural
clinics.
health.
So if the only one that I'm aware of for a variance is the FQHCs. The rural health clinic designation, I don't think would change nurses doing them. But again, Courtney, these are all great questions, and I don't want to give wrong answers. So this is a quick question for Dartmouth, though, that I can get an answer to you on.
Jason, can I ask you about the piece of information in terms of home visits? So it sounded like Medicare doesn't allow the annual wellness visit to occur in home setting, which seems like such a I don't know, lost opportunity, at least for some, right? Who are either not able or easily able to go to their primary care. And that for medications in particular, so much can be gained quickly in a home visit setting. So I just wanted to ask you, do you know if there's been advocacy around changing that to include home setting?
Yeah, great question, Rhonda. And to clarify, providers can do these in the home setting. It's that nurses, because you need that provider on site, are precluded from being able to do so. I would argue that if you have a nurse or a non-advanced practice provider doing these who knows their scope of practice, that they should be able to do them. I think it is a lost opportunity. You know, what are those tripping hazards in the home? There's so many variables that you can pick up in the home setting that's missed. Surely good question. They aren't able to do them via telehealth. That's another. I'll share my slide deck with Ed. You can I'll send that. I'll send the screening tool as well that I developed. So not just Shirley can see the screening lab tool that we created. I'll also share the article that we talked about with What's Matter. I'll share those 3 resources with everyone so they're aware of you know, the nuances. Nurses cannot do these and bill via incident to for telehealth.
That's unfortunate. It also seems like a missed opportunity. Karen.
Hi, Jason. I really appreciate the presentation. I'm a non-clinical individual program manager of the asthma program at the health department. I also kind of just am always kind of looking at the systems thing about this, and we're looking at it from a asthma perspective. Like if during your during your wellness visit, if you notice that this individual is impacted by asthma, then how would that referral go? What might be services that could be delivered at that point of contact? So that's kind of a side agenda on my point. But I wanted to ask you just about, I see you've gotten your checklist of things, and you've got your protocol, and you're trying to build this rapport very quickly, and you then try to get through your list. And that there's all these things that go awry, as I can imagine. And so I see a couple of things. One, the insurance barriers or the insurance domain, that Cars cartoon that you showed, the rusty car, of trying to get those other oil changes fixed right then and there. But then there's those utilities being off, or those other, you know, things of life that impact health. Are you able to characterize? I think of those things as revelations of those individuals' priorities. So if this is patient-driven care, those distractions or those left turns away from your checklist are indications of those priorities. Do you find that there's left turns and right turns to very specific categories of priorities that you're not able to attend to because that's not your job, but are revelations of gaps in the kind of care these individuals need? And what are the kind of groupings that you would say are predominant?
Sure. Great questions, Karen. I want to address the first one, not asthma specific, but respiratory. And this is an example from yesterday. I had a patient who shared that, they've noticed some progressive increasing shortness of breath. And, my role in part of these visits is starting to do some of the detective work. Well, she had a rescue inhaler ordered, but I was asking if she'd ever tried any sort of long-term maintenance inhaler or respiratory routine. And she said that she had in the past, but she stopped. And this was about 15 years ago. So, I'm looking back to the pulmonologist that she saw back in 2001 when she wasn't on Medicare. She couldn't afford the inhalers. So I'm not going to be able to dive into all of that in the visit. But, I make a recommendation for them to come back and to see the provider in 2 weeks. And I can kind of lay out for the provider all of the detective work I've already done and where we left off. And, said perhaps now that she's on Medicare, there's an option that would be more financially, available to her. To your second question, there are a lot of resources in the state of Vermont to help people, not just older people, but there's the Area Agency on Aging. There is the food banks, the food shelves, Hunger Free Vermont. These resources are readily available to help, and if we can make the referral and start the referral, it can go a long way. And if you give someone a phone number and they shared with you that they're hesitant to use them, and my mom taught me to never ask for help type of thing. If I can initiate that call and ask them to call the patient, it can go a long way. So it's initiating a lot of resources for the patient. I think as a practice, it's helpful to your nurses or whoever's doing these visits to start to develop toolkits for them of resources that are readily available for all of the different social determinants of health if they trigger a positive screening.
Thank you. That's very helpful.
We probably have time for one more quick question before we have to close. Anyone?
Jason, are you seeing your referrals for social determinants of health increase over time?
Oh, that's a good question. I'll say they never go away. Rarely, right? There's not quick fixes to the majority of them. It's really about trying to make those incremental changes. One of the things that's been fulfilling for me is when a provider comes to me and says, hey, your patient's lost 15 pounds. And, they relate it to the advice that they gave you about, just, doing, YouTubing chair exercises and doing 15 minutes of, chair yoga and building up your ability to do things. So if I recommend, 5 minutes, 2 to 3 times a day, and if that works, go to 3 to 5 days, or stick at 2 to 3 and go to 10 or 15 minutes. So that's been really fulfilling for me to have patients come back and have made those improvements in their lives. Well, we're just about at time. It's really been a pleasure. Thank you, everyone, for your participation. That's always helpful. Again, my email's in the chat. I'm going to be sending some resources to Ed, but don't hesitate to reach out to me. And for those of you who had questions I didn't have clear answers to, if you email me, I'll connect you with the Dartmouth team and we'll get those answered for you.
Great. Thanks so much, Jason.
Thanks,
All
Jason.
right. Thank you.
Have a good day,
Take care,
everyone. Thank you, Kat.
Thank you.